Yeah, so good evening, sir.
Hello, dear friends. I am Dr. Dipak Paruliya. Now we are discussing today the management of BPH, key drivers in a decision making in the management of BPH. Next slide. All you know, the BPH prevalence is increases where a person age is increasing. Roughly incidence around age 60, 50% suffering from BPH, and at the age of 90, almost 90 to 100% persons are suffering from BPH. Out of 50% of population at that age group, patient develop clinically symptoms, and out of 1 in 10 require some surgical intervention for prostate management. Next slide. Uh, Now in modern era, very good alpha 1 blockers and other drugs are available. So the paradigm shift from medicine to surgery. In 90s to 2020s, 20s, mainly management, 80-90% of the patient uh, almost cured with medical treatment. Now surgical intervention is required on 5 to 10, 15% of percent of BPH patients. Next slide. The main drivers for treatment decision making in BPH are, next click, progressive correctness of BPH disease and severity of low urinary tract symptoms, the quality of life and comorbidity. So we are discuss 4 points for the decision making of drug management of BPH. Next slide. The first point is basically BPH is the aging process. In that, as the age increases, the most of the persons prostate growing in a size due to the hyperplasia of epithelial cell and smooth muscles, so that increases the progressiveness of BPH. In almost 55% populations, sometime is rapidly increasing prostate size, while 30% of the approximately static remains stable, and 15% patient some static size, so that sometime quite improved or remain stable. Next slide. In longitudinal population study based survey, almost country study shows the progressiveness of BPH. In 12-year follow-up period, they found increase the international prostatic symptom score by 0.18 point per year, decrease urinary peak flow by rate by 2% per year, and the median prostate growth increases size 1.9% per year. Next slide. The risk factor for progression of the low urinary tract symptom of BPH are, next slide. As age increases, the progression of the BPH, so the symptoms are more increasing. Severity of looks, those patients are early present with severe significant symptom, that also more symptom worsening at the age increases. Prostate volume, high prostate volume size, prostate rapidly increasing the prostate size. PSA, poor flow, those patients with BPH with a significant post-birth residual urine are more likely to progress, further progression of BPH. And prostatitis. Next slide. Basically, the in a management of BPH, combination therapy rationale is that synergistic effect of combination therapy. Alpha 1 blocker treated the smooth muscle action on the bladder neck by managing the relaxation of smooth muscles, so the bladder neck is open. While 5-alpha reductase inhibitor, finasteride, dutasteride act on the hyperplasia of epithelial cell and fibroblast cell, so the decreasing the prostatic volume. So the combination therapy is more effective than monotherapy. So combination therapy का role ये है कि we with the 5-alpha reductase inhibitor we reduce the prostatic volume growth size, and by 5-alpha adrenergic blocker act as a smooth muscle relaxant, so the bladder neck is open. Next slide. Next slide. Amtopaz showed that the first time combination therapy is much more superior. Next slide. then monotherapy either by alpha 1 blocker or by finasteride 5 alpha reductase inhibitor. Next slide. So overall 66% reduction of overall progression of the disease with the combination therapy, while with monotherapy alpha 1 blocker 34%, by 5 alpha reductase inhibitor 39%. Next slide. In combat trial also showing that combination therapy of 5 alpha reductase inhibitor and Tomsilation is a first long-term study assess the combination therapy much more effective in long-term outcomes. Next slide. Second factor in progression of the BPH, in a decision-making driver, the quality of life. Basically, higher the LUTS symptom, severe LUTS symptom, have a poor quality of life. Due to the patient going frequently urination, poor flow, intermittency, hesitancy, and sometimes feeling of incomplete evacuation. So the patient not going in a party or different get-together. These patients are avoiding outdoor activities, so that they have a poor quality of life. In a studies found that in a IPSS score and FACT-G score in like prostate cancer patients, they in this study found severe lower index symptom causes similar degrees of quality of life as 80% of the patient of advanced prostatic cancer patients. So the poor quality of life is also important key driver making for management of BPH. Next slide. Basically, lower unit tract symptom in classified into three subtype: storage type of symptom like frequency, urgency, nocturia; the voiding symptom like hesitancy, intermittency, poor flow, feeling of incomplete evacuation, and post-maturation symptoms. The lower unit tract symptom is over in BPH is a overlapping symptoms. Some patients have a more voiding dysfunction, some patients have more storage function dysfunction, some patients have all three type of combination. So the 45% of the men have a bladder outlet obstruction having coexisting with overactive symptom. So that in 45% of the LUTS in BPH is a mixed type of symptoms. Next slide. In the management algorithm for the LUTS management, in male LUTS patient, those patients have a purely or mainly storage function like frequency, urgency, nocturia. These patients are ideally treated with antimuscarinic agent, while those patients with combination with LUTS, voiding and storage type of symptoms or predominantly voiding LUTS are mainly initially treated with alpha 1 blockers like tamsulosin, silodosin. After that, if a patient had not sufficiently improved or still a storage type of symptom is persisting, then after starting of therapy after 1.5 months or 2 months, 4 to 6 weeks, we can add antimuscarinic agent. Not initially day one. Otherwise, patient have a risk of urinary retention or symptom worsening. Next slide. So guideline recommendation for the in the algorithm treatment of LUTS in European Association of Urology guideline 2016, they found use combination treatment with alpha 1 blocker with antimuscarinic receptor antagonist patient with moderate to severe LUTS. In those patients who have both type of storage and as well as voiding LUTS, but not started with monotherapy, especially in a significant PVR post-word residual urine. If we started initially with antimuscarinic treatment, pure monotherapy, then patient risk of developing acute urinary retention. So that these patients ideally should be started with alpha 1 blocker, and later stage we can add with some antimuscarinic drugs. While NICE guideline 2010 consider offering anticholinergic as well as alpha 1 blocker in combination therapy, we can start with mild storage symptom with voiding dysfunction. Next slide. Next, third key driver for management of BPH is a comorbidities. Due to the BPH disease after 40s, after 50s, and after 50s as an aging process, many comorbidities develop along with the BPH, like almost 40-50% patient develop cardiovascular disease, 50-55% patient associated with hypertension, diabetes, overall metabolic syndrome, while 70% of the BPH patient suffering from erectile dysfunction and andropause due to the decreasing the testosterone hormone level. Next slide. So the comorbidities have a negative impact on the management of BPH. Next slide. In the algorithm of Lutz management, the male Lutz patient, if patient was not having any bothersome symptoms, there are minimal mild symptom, occasional symptom, these patients ideally not require treatment. Just we ask them watchful waiting or lifestyle management, and about educate about you decrease evening time, less liquids, less fluids, avoid drinking in a late hours, like that. If a patient have a bothersome symptom, then we initially ask them. If a patient have a specifically nocturia is only pure symptom, then these patients with lifestyle management and education, we add with vasopressin analogs. While patient have a day and evening, both time patient have a Lutz, mainly storage type of symptoms, then we add the along with the lifestyle management as well as antimuscarinic drugs. If patient have a mixed next slide, please. Thank you. Now we discuss the second part
Yes.
of the management, basically approach 360-degree approach management of BPH, specifically silodosin molecule. Next slide. Silodosin molecule have a highly uroselective alpha 1 blocker. Mainly alpha 1A and alpha 1D is on a bladder neck and trigone area. So that required in BPH patient relaxation of bladder neck, while alpha 1B is mainly predominant in blood vessels. So the more hypotension, more vasodilatation is occur. Like in older drugs like dexazosin, terazosin, these drugs are causing more postural hypotension, as well as alfuzosin also have a similar type of more equivalent alpha 1B activity, while tamsulosin and silodosin relatively very less alpha 1B activity. Next slide. In among them, silodosin have a highly uroselective alpha 1A, alpha 1B selectivity ratio is 583 times over alpha 1A receptor, while tamsulosin only 15% ratio. So the silodosin is a very good molecule, least side effects. Silodosin has a rapid onset. In that graph showing rapid onset of the relief of symptoms, it almost significantly require almost half week, 3 to 4 days, the symptoms results improving. Next slide. Significant improvement of IPSS score in BPH patients sustained over 12 weeks. It means up to the 12 weeks, 3 months, the maximum relief from these medicines. And it's a silodosin molecule Qmax increases 2 to 6 hours is a very good effect and early results after giving a first dose. Next slide. Same. And silodosin have a more affinity to alpha 1A and alpha D related to alpha 1B. That's why it's a more cardiovascular safe in comparison to tamsulosin, alfuzosin, and terazosin. So the very least chance of postural hypotension in silodosin group. Next slide. No increased risk of orthostatic hypotension is observed in these studies, especially in elderly patients and cardiac patients. and patients those are taking hypertension management. And these patients, no clinical relevant changes observed during Saladosine treatment in blood pressure, even systolic as well as diastolic blood pressure and heart rate in comparison to placebo. Next slide. The same slide. Next. So the management of BPH and Saladosine in other comorbidities. Next slide. Next. In epidemiology, first slide already showing in a 40s almost 8% prevalence, 40s age group 8% of prevalence, while in 90s age group almost 80 to 90% of persons suffering from BPH. In out of that, in BPH patients, comorbid hypertension is found in 56%, comorbid cardiovascular disease in 46%, and erectile dysfunction almost 40 to 70% of the in these BPH population. Next slide. Hypertension and cardiovascular disease are most common comorbidities in BPH. Next. In management of BPH, specifically in hypertension patient, we found that older alpha-1 blocker considering significantly hypotension. So that most of the time we start with a lower dose, specifically Hytrin. We are starting the lower dose and we titrate that gradually increases. But newer alpha-1 blockers are more uroselective, so that not affecting the blood pressure status even in patient on hypertensive. So that we conclude that alpha-1 blocker are first line treatment for patient with BPH with LUTS, and alpha-1 blocker are most commonly prescribed medicine in BPH in these patients. And non-selective alpha-1 blocker has an increased risk of cardiovascular side effects, like sometimes most alfuzosin, most of the patients have postural hypertension, as well as few patients of tamsulosin is also have postural hypertension, while in Saladosine is a least postural hypertension. They are much safer. Saladosine has an advantage in almost same thing. Next slide. Saladosine advantage in BPH associated with hypertension. It did not increase the dizziness, weakness, and postural hypertension. Only 8% of the patient suffering from ejaculatory dysfunction, like due to the bladder neck opening, the patient have a retrograde ejaculation or an ejaculation, while only 2.5% patient require stopping of this medicine due to side effects. So the more cardiovascularly safe these medicine. Next slide. Saladosine molecule with a low incidence of treatment related adverse effect like dizziness in 1.9%, erectile dysfunction on 1.5%, diarrhea 1%, headache 1%. Only 8% patient have a reported discomfort ejaculatory changes. No patient, almost very minimal patient suffering from postural hypertension. No patient discontinued due to abnormality in labs or ECG parameters. Next slide. The Saladosine improvement in a study found that from IPSS score, widening score from 10 to 5.7, and storage symptom 8 scoring to 4.9%, and overall IPSS from 18.9 to 10.6. So it better for both mixed type of symptom. Saladosine is a better molecule. Next slide. Erectile dysfunction in BPH due to the aging process and other hormonal changes, so that require some persons require erectile dysfunction management with BPH. The ideal molecule is either tadalaflo or Saladosine. Both can be used at patient's requirement. 5-PD inhibitor used along with alpha-1 blocker. Due to the both medicines are vasodilator, it can cause hypotension. Specifically, alfajocin or terazosin or doxorubicin usually avoided with a 5-PD inhibitor. So while Saladocin can be used, relatively safe. Next slide. Next slide. So overall, Saladocin clinical advantage in BPH patients. Next. It also increases the quality of life of score. If a nocturia patient, if patient have not having a sound sleep, if is going urination frequent time, that overall day and night, both time, the quality of much poorer. So that quality of life score, if patient going one time nocturia is scoring 91, while those patients are going 4 to 5 times, the quality of life score is 67. So the in studies found the Saladocin molecule have a relatively much more improvement in nocturia. In that study found that reduction of more than 1 to 2 episode in nocturia from baseline placebo drug and other drugs. That is significant. Next slide. Next. The Saladocin in this studies found that next. In that study also found that nocturia incidence with Saladocin is increasing significantly. Next. The Saladocin consistently induced significant greater reduction in nocturia within each study and overall patient cohort quality of life score. The explanation about that, it not exactly found in that clear, but they found significant symptom improvement in nocturia, especially due to the alpha 1A selectivity of molecule, uroselectiveness of. That's why less vasopressure, less hypotension, less nocturia. In comparison of Saladocin and Tamsulosin in both molecule, next slide. In these studies found overall much more IPSS total score improvement, widening symptom score improvement, storage symptom score improvement, feeling of incomplete emptying, frequency, straining, nocturia, quality of life is much more significant improvement compared to Tamsulosin. Next slide. Urodynamic parameter changes in bladder outflow index. Saladocin have a significant improvement. In this graph showing that Terazosin bladder outlet index improvement found in -6, while Tamsulosin -14, while Saladocin have a -30. So it's quite very good effectiveness of this drug in comparison to other alpha 1 blocker. Next slide. Next. Saladocin role in acute urinary retention is a very good role. We found in success rate of trial without catheter, after giving a acute urinary retention, we give 5 or 7 days Saladocin, and after that catheter out. Out of that, 76% of Saladocin group found voiding the patient in comparison to 36% from placebo drug. Next slide. Next slide. The combination therapy, Saladocin with dutasteride or Saladocin with finasteride, the combination therapy is a much more effective than monotherapy. It reduces the risk of progression compared to monotherapy. Combination therapy provides a significant better symptom control and better symptomatic relief. Combination therapy is significantly more effective than monotherapy. So the less chance of the patient underwent acute urinary retention or later on required surgery. Next slide. So the patient suitable for combination therapy, so lesser risk, those patients have a severe loads, large prostate, or patient have a severe urinary tract symptoms, and due to the combination therapy, more potential synergistic effect by different mode of action. Next. Clinical predictors of BPH progression. Those patients have a large prostatic volume, more than 30 ml, have a relatively higher PSA, more than 1.6 nanogram per deciliter, poor flow, less than 10, peak flow, less than 10 ml per second. Patient have a relatively higher post-word residual urine, more than 10% of clinical significant bladder capacity, roughly around 40 cc, more than 40 cc, and the higher the age, then more chance of the BPH progression in these patients. Next slide. This graph showing the combination therapy are much more effective compared to monotherapy. Next. So the salutation improve IPSS and IPSS quality of life by the after 2 week, 4 week, 8 week, 12 week, we comparing the graph, a significant improvement and less chance of acute retention, decrease the PSA in later on, and decrease the prostatic volume. Next slide. In combination therapy of saludosin and antimuscarinic drugs required sometime, specifically the patient have a mixed type of symptoms. Patient have a intermittency, hesitancy, overflow, as well as increase the frequency, irritative symptom, urgency. Sometimes these patients required, along with saludosin, we require add with antimuscarinic drugs. Next slide. Next. The safety profile of saludosin. Next slide. Combination therapy as well as monotherapy, both are relatively much safe and well tolerated. Saludosin have a very least side effect, so they are not associated with increased chance of dizziness, orthostatic hypotension, ECG parameter change, and BP changes. In a study found that only 8% of the patient found ejaculatory dysfunction, mainly retrograde ejaculation or anejaculation, while 2% of patients require drug withdrawal due to the ejaculatory dysfunction. So usually we avoid in the young patients. One more interesting point in this study found that those patients have in BPH patient, erectile dysfunction patient, or ejaculatory dysfunction, those patients already anejaculation or delayed ejaculation or ejaculatory dysfunction and severe loads patient, those patients are much more improved with the saludosin comparative to without ejaculatory dysfunction. So the patient with ejaculatory disorder may have a very large symptomatic improvement with saludosin. Next slide. So in conclusion, next slide, we conclude the comorbidity like
recording in progress.
Comorbidity like hypertension, cardiovascular disease, erectile dysfunction are common in BPH. Since alpha-1 blocker can potentially have a drug interactions with adverse outcome when administered with drug used in hypertension, cardiovascular disease, and erectile dysfunction. So the treatment should be carefully chosen. Which type of alpha blocker should be used? Saludosin, among them, saludosin is a much more effective and safe to administer with antihypertensive drug as well as in erectile dysfunction management drug like sildenafil, 5-PD inhibitor. Saludosin have a very low propensity of orthostatic hypotension and cardiovascular side effects. Saludosin is effective in improving urodynamic parameter like IPSS score and bladder outlet inflow index. In selective patient, combination therapy are much more useful overall compared to monotherapy. And combination alpha-1 blocker and 5-alpha inhibitor like saludosin and dutasteride can act synergistically. Combination therapy not only effective in improving symptom but also effective in decreasing the progression of disease. So the overall quality of life improve of these patients. Saludosin monotherapy and combination with dutasteride well tolerated. The rate of ejaculatory dysfunction causing discomfort and discontinuation of therapy very minimal, 2 to 5% patient with saludosin. In fact, some patients with previously already ejaculatory dysfunction associated with a high improvement in BPH, IPSS score improvement. So our preferred molecule in a BPH management, alpha-1 blocker, is saludosin. Other role of saludosin, alpha-1 blocker in medical, now we are using in small lower ureteric stone. especially lower ureter due to the alpha 1A and alpha 1D receptors found in the lower ureter, especially in VUJ area. In these studies found that stone size roughly 5 to 10 length size in comparison with the tamsulosin or placebo have a significantly much more expulsion of the stone with salidocin of therapy of 2 to 4 weeks. Less requirement of analgesic and relatively less time of expulsion in comparison to other placebos. Next slide. Thank you. Any question? We are welcome. अच्छा, चैट बॉक्स शो करें, मुझे आ नहीं रहा है. Can we
Yes, sir.
question is how long time we prescribe Urimax in BPH with diabetic patient? Can we give as much as he needed? If we are giving alpha 1 blocker, if patient not improving, then we follow up with the uroflowmetry and ultrasound. If we flow is not improving, then patient require other combination or seeking the surgery. If patient have a significant improvement, it should be continued. It can be given 2 year, 5 year. If after follow up, patient have a significant improvement, prostate size reduces less than 20-25 ml. We not need of combination therapy, just give monotherapy. The mostly diabetic patient are suffering from frequency problem. How we know that it due to diabetes or BPH? Very good question. With wide patient, we ask patient to make a voiding diary. In a diabetes, mainly polyuria. In a BPH symptoms or bladder storage symptom, patient have a significant frequency, urgency, nocturia, not polyuria. Also good question. The surgical indication of in BPH is a selected indication like acute retention. A patient, if giving a trial after 5 to 7 days, it also fail. Then he is ideal for management by either HOLEP or TURP. Second, recurrent hematuria, bladder stone, recurrent UTI, patient not responding on alpha 1 blocker, patient is still have a poor flow, significant IPSS score, a poor quality of life, and these patients with stricture ideally require surgery. What will be the choice of molecule in patient in sexually active, suffering from BPH? In young patient, specifically young patient, and prostate size not much increase, we start with alfuzosin initially. If a patient have a clinically bothersome, more poor symptoms, higher IPSS score, sometimes alpha blocker like alfuzosin not effective, then we start with salidocin. But ask them some 8 to 10% patient have a ejaculatory disorder, so that these patients may suffer from retrograde ejaculation, but erectile dysfunction is relatively quite maintained. Silofast, how long can we give maintenance therapy in old patient? It's a quite safe. Can we give 5 year, 10 year? A safe drug. Yes, good question. We basically, specifically in a pre-cataract surgery, ideally avoid the tamsulosin or salidocin. Some floppy iris syndrome we are reported. Otherwise, in glaucoma, they are salidocin or tamsulosin, no significant role. Any other question?
Okay.
How long mirabegron and sulfasalazine combination can be given? Mirabegron is a newer drug for beta 3 agonist
Okay.
used in overactive bladder symptom. Mirabegron is safe, can be given 2 year, 5 year, but antimuscarinic drug not given for too long, 3 months, 6 months, or 1 year. Higher risk of neurodegenerative changes in the, with the anticholinergic drugs. Contraindication of combination therapy, yes. In young patient, sexually active patient, we are preferably avoid dutasteride and finasteride due to the increased risk of developing erectile dysfunction and poor libido. Yes, tadalafil and saladosine, we are giving. Tadalafil is a 5 milligram with saladosine 8 mg or 4 mg can be given in a erectile dysfunction patient with BPH. No more question. Thank you. Thank you. Yeah. Thank you everyone for listening my talk on the overall 360-degree management of BPH, specifically focused to saladosine. Thank you.